Okay, this is our agent presentation. My name is Jaslyn. Also in our group, we have Olivia, Kinsey, and Eduardo.
Our scenario is in an oncology unit of a busy hospital. Nursing leadership faces a scenario that necessitates a change in clinical guidelines for pain management. The unit primarily cares for cancer patients undergoing various treatments, and pain management is a critical aspect of their care. However, concerns have arisen regarding the adequacy of the current guidelines. The opioid crisis has prompted increased scrutiny on opioid use in healthcare. The current guidelines may not reflect the latest evidence-based practices for opioid stewardship, including strategies to minimize the risk of addiction and overdose. There's a growing recognition of the importance of patient-centered care, including individualized pain management, plans tailored to each patient's unique needs, preferences, and cultural factors.
So, some of the potential areas of improvement for this kind of scenario, we got off of some articles with the research that we did regarding this topic. And one of the articles was using a soluble film fentanyl, uh, like a buccal route form of fentanyl in cancer patients, using these to reduce breakthrough cancer pain, which is really important, as we know, like cancer pain is the most painful pain that anybody could feel. So use of this form of like analgesia worked really well in these kinds of patients, as we found out through reading that article. Another thing that we found out is some adequate insurance coverage for analgesic options is something that could be a potential area of improvement as you're having all this horrible pain. Like the last thing that you want to be worrying about is if your insurance is going to cover all these medications needed to treat that kind of pain. Another thing was including patients in care plan to maximize safety and address their concerns regarding opioid treatment. I don't know if this happens to everybody or if it's just me, but it was also mentioned in the article. But I've heard so many people within the hospital like say they do not want to take pain medicine because they're afraid of being addicted because their mom was or their dad was or they know people that have had addictions. And so including patients in a care plan to safely take pain medicine and address those concerns with the opioid addiction stigma would be really good change to improve.
And then this was also said in another article was the to encourage the enrollment in opioid stewardship programs. These programs can help reduce misuse and abuse of opioids, and they can also help reduce the stigma for patients who do choose to take the opioid option to help relieve their pain and just help them understand and deal with the stigma that kind of comes with the opioid use.
And then having more comprehensive data on opioid use and the risk factors available to nurses and physicians can help them be more knowledgeable and educated so that they can help address those concerns that some patients may have just from not knowing or needing more information. And then that kind of goes into like having a focused education or training program for healthcare providers that are working with cancer patients who need opioid treatment.
So again, going off of the articles is the actual areas of improvement that we can make based on all of our potential areas of improvement. So some of these articles were talking about policies need to be placed for like oncology units or on oncology clinics. There needs to be some sort of like policy change regarding the amount of pain medication that could be given. There is always a risk for respiratory depression, especially with opioid use. And so policies kind of would have to be formed inside of that as well. But there needs to be some sort of like increased dose or different kind of management plan for these oncology patients as their pain is extremely chronic and brutal. So that's something that could be changed for actual improvement. Additionally, education on shifting the biases towards opioid use in cancer patients was something mentioned in that same article. And this just kind of goes on the fact that a lot of healthcare workers, not just nurses in general, and a lot of the regular population has this bias on opioid use and addicts, and it just goes to the stigma behind that. But education on shifting that bias, especially when it comes to oncology patients, would be a huge area of improvement because you have to understand that it's the worst pain that they're going through, and you need to not be biased and think that they're like drug seeking all the time when they really just want to not be in pain anymore. The next thing was evaluating and expanding nursing competency regarding the management of cancer pain. So this kind of ties into the last two that I mentioned, regarding like competency into following new policies and providing that education and making sure the education is understood. And then, so medications available for breakthrough cancer pain. This kind of goes back to that buccal fentanyl film that I was talking about. There seems to be some other medications that could be available for pain management that maybe not every access or sorry, not every hospital or clinic has access to. And so if that's something that is, stocked like your regular Tylenol or whatever, it would be easier for these patients to get access to the kind of medication that will actually help them. And then last but not least is providing and prescribing alternative analgesics to cancer patients in place of opioids, because in one of the articles that I read, there was the group of cancer patients were talking about how their oncologists were just so quick to prescribe opioids. Like they didn't try to focus on any other non-pharmacological things, or any lesser opioid medications to prescribe them for the pain. And part of that like is nice in a way because they're wanting to treat that pain, but it is also hard because of the stigma and people not wanting to get addicted. And additionally, like there's been a lot of research done on how non-pharmacological things could be helpful in pain relief. And like I said, they're just way too quick to prescribe this. And so maybe with some further education, providers would be less likely to just jump to the gun.
So, who may be needed to assist in changes? Obviously, the patient's pain is subjective and pain is what the patient says it is. It's important to listen to the patient and understand what kind of pain management they want to use because not all patients want opioids. And some would prefer the less intense drugs like ibuprofen, Tylenol, or even some non-pharmacological pain interventions. And then secondly, obviously the providers in a previous article that or an article we read for this um project, some of the patients expressed their feelings about their providers and how they were being treated. And so some of the examples I read were patients felt like the providers were too quick to prescribe opioids. So like just how Jazz said, opioids were just the first pick for the provider. They didn't even think about any alternatives. Patients also found it difficult to get alternative therapies from their providers. So again, just the automatic use of opioids rather than something less intense like Tylenol or even the non-pharmacological pain interventions like ice packs or warm packs. And then lastly, they also said that they were disappointed in the lack of clarity over the use of opioids and the safety risks that come with those opioids. They just felt that there was never clear communication between the provider and then them as a patient on why they were to take this medication. And so it would be for these changes to occur, there just needs to be clear communication with patients about their pain management expectations, what that normal pain level is for that patient, and what is too much. some more clear guidelines on treatment regimens and how to taper and discontinue use of opioids if that is what the patient decides to do, because it is important that there is a process of slowly weaning the patient off of opioids so nothing bad happens. And then lastly, nurses, we are the in-between between the patients and the providers. So it's important that we assess their pain and administer pain medications. It's also important we provide education on pain management and the use/risks of opioids, and then provide education on the safety aspects of opioids and what to do in the case of an overdose.
So going into the actual plan to improve these issues, one of the articles that I have cited here goes into different approaches and techniques to address opioid or the issues within opioid treatment and management for cancer patients. And one of the things it talked about was using motivational interviewing between the nurse and the patient to build rapport, promote behavioral change, and channel individual self-efficacy. And this allows for the patient to have time to express their concerns about the use of opioids, identify any bias that they may have, and establish treatment goals, whether they want to use more opioids, less opioids, more non-pharmacological things, and overall help the patient cope with their illness. And then another thing is for the nurses to work with their patients to develop individualized harm reduction plans to maximize their safety and encourage engagement in improving health and function. This includes going over patient education over their medications they'll be taking for pain, going over any like potential side effects, benefits, overdose prevention, and other options for alternative management, and then a plan for their breakthrough pain. A harm reduction plan places a person's well-being at the center of the intervention, which promotes humanization, dignity, choice, quality of life, and healing. And then another important thing is to implement integrated annual and onboarding training for programs for new and current staff regarding safe prescribing and monitoring, bias awareness, competency in alternative pain management, and opioid oversight and de-escalation strategies. This would help address the areas of improvement we discussed earlier, as well as improve patient safety, optimize pain management, and foster a more informed and equitable approach to opioid use in cancer care.
Okay, so how the scenario relates to Lewin's change model. Um, Lewin's change model is broken down into three parts. It's the unfreezing, the changing, and then the freezing phase. In the context of these articles, unfreezing is seen in the identification of issues with the current pain management strategies in oncology. These articles highlight the problem of quick opioid prescriptions without exploring alternative multimodal approaches for pain management. The urgency of addressing opioid misuse, addiction, and overdose risk represents the need to challenge existing practices and perceptions. Changing. This stage involves implementing the change, trying new approaches, and providing support for the transition. In the context of these articles, the changing phase is represented by the move towards a multimodal team management strategies. The articles discussed the implementation of safer opioid management practices, such as using motivational interviewing, harm reduction, and patient-centered care. The push for improving health professionals' capability in cancer pain management by enhancing their knowledge about opioid and pain management practices is a crucial part of this stage. And then freezing. In this final stage, the new behaviors, practices, or changes become integrated and institutionalized. And in the context of these articles, freezing happens when the new evidence-based pain management practices become standard practice for oncologists and the rest of the healthcare team. It involves making updated pain management approaches such as multimodal treatments, opioid safety strategies, routines, and oncology care. The research suggests that enhancing nursing knowledge, increasing awareness about opioid misuse, and integrating new practices into cancer care will lead to better outcomes and a shift in how oncology pain is managed long term.